Patient's here.
Oh boy, got some blood going.
Yeah, this is never blood.
Oh, he's wearing it too.
Welcome to the bed. When you get over to the bed, we'll go ahead and give you the story. This is all going to happen super fast. Welcome to the emergency room.
70-year-old female, single driver vehicle, appears that she went off-road into a ditch, rolled over, her car into a tree, caved in, the top of the vehicle was caved in, so she was hanging out partially from the window. She's been in application
for 45 minutes of CPR. We can stop CPR with 600, 600, 600.
Welcome back to the Deep Dive. We are glad to have you with us. Today, we are wading into waters that, let's be honest, they can terrify even the most seasoned nurses, let alone students who are getting ready for their boards.
Oh, absolutely.
We are talking about pediatric pain, specifically the assessment and management of it. And I was looking through the stack of articles and the textbook chapters, all the clinical guidelines we're covering, especially chapter 14, and it hit me. This is arguably the most subjective, high-stakes game of poker you can play in medicine.
It absolutely is. I mean, the stakes are just incredibly high because you're dealing with a population that, often can't advocate for itself.
Right.
You're looking at a patient demographic that ranges from, a 24-week preemie in an incubator who literally lacks the anatomy to speak, all the way up to a 17-year-old linebacker who is just refusing to speak because he thinks admitting pain makes him look weak.
Yeah.
And if you, as the clinician, if you get this wrong, if you miss the signs, the consequences aren't just, the kid has a bad afternoon.
Right.
We're talking about real physiological damage, long-term neural sensitization, and frankly, massive ethical failures.
Right. And looking at the sheer volume of material here, I mean, it is dense. You've got developmental theories, a dozen different pain scales, pharmacology profiles, legal frameworks. It's overwhelming.
And too much to memorize.
Exactly. So for this deep dive, we are going to apply the Pareto principle.
The 80-20 rule. I love this approach for complex clinical topics. It just cuts through the noise.
It really does. The whole premise is that 80% of your results, or in this case, 80% of the safety questions on the NCLEX and 80% of the life-saving decisions you make at the bedside, they come from just 20% of the information. So our mission today is to filter this stack. We want to clearly distinguish the need to know, the stuff that keeps you out of court and keeps your patients safe from the nice to know, which is, the deeper context that helps you understand the why, but it isn't necessarily the make or break data point for a tiered exam.
Which is so crucial because exam writers love pediatric pain.
Oh, they do.
It's a favorite target. It really is. It forces you to synthesize. You can't just memorize a drug dose. You have to look at a whole scenario, interpret a behavior, navigate a complex family dynamic, and spot the trap. And believe me, there are so many traps in this topic.
Okay, so let's map this out. We're going to structure this logically, essentially following the nursing process. We'll start with section 1, the mindset shift. This is where we have to dismantle the myths that cause students to fail. Then section 2 is the framework. That's the QUESTT mnemonic. Section 3 is the tools, specifically the rules on which scale applies to which age.
The rules are everything there.
Section 4 is the detective work reading the body when the mouth is silent. Section 5 is pharma, the safety protocols for drugs.
Yeah.
And finally, section 6, the art of nursing, all the non-pharmacologic interventions.
It's a really solid roadmap. And I think starting with the mindset shift it's non-negotiable. Because historically, the medical community has gotten this wrong for a long, long time. If you walk into a pediatric room with the wrong assumptions, you will undertreat pain every single time.
Okay, let's unpack that. Section 1, the mindset shift. The source material highlights several myths or misconceptions. And looking at the need-to-know bucket, our 80-20 core, there is one trap that just seems to catch everyone: the sleeping trap.
This is the #1 red flag on exams and in clinical practice. Let's paint a picture here. Let's say you have a patient. Let's call him Lucas.
Okay.
Lucas is 4 years old. He had an appendectomy this morning.
Yeah.
You walk in at 2 p.m. to do your rounds. Lucas is curled up in bed, eyes closed, fast asleep. Or maybe he's awake and he's playing Mario Kart on an iPad.
Right.
The instinct, the trap, is to chart 0, 10, 0 pain and walk away.
Which feels intuitive, right? I mean, if I'm in agony, I am not sleeping, and I'm certainly not playing video games. I'm writhing.
That is adult logic. You're applying adult logic to a pediatric brain, and that is where you fail. The source material is it's explicit on this. A child who is sleeping or playing is not necessarily pain-free. In fact, they could be in severe pain.
So what's actually happening there physiologically? Why would a child in pain be asleep?
It's a coping mechanism. And sometimes it's just pure, unadulterated exhaustion. I mean, think about Lucas. He's been in a strange environment. He's been poked with needles. He's had major surgery. His body's flooded with cortisol. He might have spent the last 3 hours fighting the pain, crying, tensing up all his muscles.
Yeah.
Eventually, the battery just runs out. He crashes.
Wow.
He isn't sleeping because he's comfortable. He's sleeping because he has nothing left in the tank. If you wake him up, or if you just check his vitals, you might find his heart rate is still racing, his breathing is still shallow.
So sleep can be a form of shutting down. It's not a sign of peace.
Exactly. And regarding the video games, distraction is an incredibly powerful analgesic, but it's also a wall. A child might focus so intensely on that screen because the second they look away, the pain rushes back in. It's a dissociation technique.
Got it.
So for the exam writers, this is key. If you see a question asking, the child is sleeping post-op, do you wake them to assess? Or do you administer the scheduled pain med? The answer is always yes. You assess. You never ever assume sleep equals comfort.
That is a critical distinction. It's not just let sleeping dogs lie. It's check if the dog is actually unconscious from exhaustion.
That's a perfect way to put it.
Okay, the next big one in the need to know category is the newborn myth. And this one is hay. Well, it's horrifying when you look at the history of it.
It is. I mean, we don't have to go back that far, maybe to the 80s, to find a time when major surgeries were performed on infants with minimal or sometimes no anesthesia.
That's unbelievable.
The belief was that their nervous systems weren't myelinated enough to transmit pain signals.
Yeah.
Like the wires just weren't hooked up yet.
Which we now know is completely false.
100% factually incorrect. The 80-20 takeaway here is really simple. Newborns do feel pain. Their neurologic system is absolutely intact enough to perceive it. In fact, in some ways, they feel it more intensely because they lack the descending inhibitory pathways that adults have to kind of dampen the signal.
So they just get the raw feed.
The raw feed, no filter.
And this connects directly to the next one, the memory myth. The old idea was, well, even if it hurts them, they won't remember it, so it doesn't matter.
Right, they're babies. They don't have narrative memory. And that part is true. Lucas won't remember the specific nurse who poked his heel when he was 2 days old.
Okay.
But his spinal cord remembers. This is the whole concept of sensitization, or what we call wind-up.
I was reading about this in the source material. It describes actual changes in the cellular structure, like physical changes.
Yes. Think of the spinal cord like a volume knob. If you expose a newborn to repeated, painful stimuli like heel sticks, suctioning, intubation without adequate pain management, the cells in the dorsal horn of the spinal cord become hyperexcitable. You are effectively turning the volume knob all the way up and then breaking it off.
So fast forward 5 years. What does that look like?
Exactly. 5 years later, Lucas goes for a routine flu shot. A normal kid might say, ouch, and be fine 30 seconds later. But Lucas, whose system is sensitized, might experience a level 10 trauma. His body overreacts because that neural pathway was blazed wide open when he was a neonate.
Wow.
So treating pain in a newborn isn't just about kindness in the moment. It's about protecting the entire architecture of their developing nervous system.
That adds so much weight to the decision to use analgesia. It's not just comfort, it's neurology.
It's preventative neurology.
Okay, let's move up the age bracket, the truthfulness trap. This seems to apply more to the toddlers and preschoolers.
It does. The assumption here is, if it hurts, they will tell me.
Which, again, seems logical. If I step on a Lego, I'm letting everyone in a 5-mile radius know about it.
But you're an adult with reasoning skills.
Yeah.
A child has completely different motivations. Let's go back to Lucas, our 4-year-old. You walk in with a stethoscope and you've got a syringe in your pocket. You ask him, Lucas, does your tummy hurt? He looks at the syringe. He knows that if he says yes, you might come closer with that sharp thing. So he says no.
He's trading long-term relief for short-term safety.
Exactly. To him, the shot is terrifying. It's an immediate known threat. The pain in his belly is a constant dull threat. He chooses the devil he knows.
And it's not just toddlers. What about a teenager?
Oh, absolutely. A teen might deny pain because they want to feel in control, or maybe they're an athlete and they've been taught their whole life to walk it off or play through the pain. Admitting pain feels like a failure of character to them.
So the idea that self-report is the gold standard, it really comes with a big asterisk.
A massive asterisk. It is the gold standard only if the child is capable and willing to be honest.
Yeah.
If the child says no pain, but they are grimacing, their body is rigid, and their heart rate is 140, You trust the body, not the mouth.
That's the detective work we'll get to later. Before we leave emits, we have to touch on the elephant in the room. Opioids. This comes up constantly with parents. Don't give him morphine. I don't want him to get addicted.
This is a huge, huge barrier to effective care. The need to know here is crystal clear. Children are not more prone to addiction than adults when they're being treated for acute pain. And physically, they do not experience more adverse effects than adults.
So the fear is largely unfounded, at least in the acute setting.
In the context of treating a broken femur or post-surgical pain, yes, of course we are careful. We monitor closely. But we do not withhold necessary analgesia due to an irrational fear of creating an addict in 3 days.
Right.
In fact, the source material emphasizes that untreated pain can actually be a driver for chronic pain issues later on, which is a far, far bigger risk factor for substance use disorders down the road.
Okay, so that really covers the mindset shift. We know sleep is a trap. Newborns are wired for pain. Memories are physiological. Kids might lie to avoid shots. And opioids are safe when they're managed properly. Let's look briefly at the nice-to-know context here. The sources mention things like culture and temperament.
Right, and this is the 80% the supporting info. It's good to have in your back pocket. Just be aware that pain is filtered through culture. In some families, a boy crying is seen as shameful, so be stoic. In others, expressive vocalization is encouraged and expected. You have to read the room. And temperament, an easy temperament child might just whimper quietly when they're in agony, while a difficult or intense child might scream bloody murder over a hangnail. You have to calibrate your assessment to the baseline personality of that specific kid.
Context is everything. Okay, let's move to section 2, the framework. We have a mnemonic here. QUESTT. And that's QUESTT with 2 T's. QUESTT.
This is your safety net. If you freeze up in an exam or in a real clinical situation, just walk through these letters. It'll guide you.
Let's break it down. Q.
Question the child. This is always the first step. But as we just discussed, how you question them matters so much. Don't just ask, do you have pain? Ask, where is the hurt? Or can you tell me how your tummy feels? You have to use their language, owie, boo-boo, whatever works.
Yeah.
Use a reliable pain scale. And the emphasis there is on the word reliable. This is a huge exam point. You absolutely cannot use a scale designed for an adult on a toddler. You can't use a self-report scale on a baby. We're going to deep dive into the specific age rules in just a minute, but use your reminder to pick the right tool for the job. Evaluate behavior and physiologic changes. This is your backup. This is what you do when the cue fails. If they can't talk or they won't talk, you look. You look at their face, their legs, their vitals. This is absolutely crucial for the nonverbal population.
Secure parents' involvement. I feel like this can be a double-edged sword for some nurses. Sometimes the parent feels like an obstacle, not a help.
And that is such a dangerous attitude to have. The need to know here is that the parent is the expert on that child. You've known Lucas for 4 hours. His mom has known him for 4 years.
Good point.
If she says he isn't acting right or he looks like he's in pain, you believe her. You believe her even if the monitor says his heart rate is within normal limits for his age. She knows his subtle cues, the way he holds his lip, the way he goes quiet before he cries. Securing their involvement means using them as a primary data source.
That's a great clinical pearl. Never bet against the mom. Okay, T and T.
First T. Take cause of pain into account. This is pathology. If a child has sickle cell disease, that's ischemic pain. It is excruciating. Even if they're sitting quietly watching TV, you know the underlying pathology warrants aggressive pain control. Don't let a coping behavior override your knowledge of the disease process.
Got it. And the last T.
Take action. Assessment is completely useless without intervention. If you find pain, you must do something. Give medication, reposition them, use distraction, and then critically reevaluate.
It's an action loop. Assess, act, reassess. Okay, let's get into the weeds. Section 3, assessment tools. I feel like if there was a red alert section for testing, this has to be it. Exam writers just love to give you a scenario, a 4-year-old boy, and then ask you which scale to use.
Absolutely. This is probably the highest yield section of our entire discussion. If you use the wrong scale, your data is garbage. It's meaningless. And on the NCLEX, using the wrong scale is a safety violation. You fail the question.
So let's lay down the age rules. Let's start with the most famous one, the Wong-Baker Faces Scale. We've all seen it. The little cartoon faces ranging from a happy smiley face to a full-on crying, frowning face.
Right. The target age for the FACES scale, the number to burn into your brain, is 3 years and older.
3 3 seems young. I mean, can a 3-year-old really understand that concept?
They can, but, and this is a huge need to know, you have to explain it correctly. You can't just point to the chart and say, pick a face.
What do you say?
You have to anchor the scale in pain, not emotion. You have to explain, this face pointing to the 0 has no hurt at all. This face pointing to the 2 hurts a little bit. This face pointing to the 10 hurts the most.
Oh, so you use the word hurt.
Yes. The word is hurt, or OE, not sad or happy.
Why is that distinction so important?
Because a 3-year-old might pick the crying face because they're sad that mommy went to the cafeteria, or because they dropped their teddy bear on the floor.
Right.
You have to clarify that the faces represent hurt, not just sad. If you skip that instruction, the tool is completely invalid.
Okay, so faces is 3 and up with the right instructions. Now, what about the numeric scale, the standard 0 to 10 that we use for adults?
The target age jumps up here. This is generally for 5 years and older.
Why the 2-year gap? Why can't Lucas, our 4-year-old, use the numbers? He can probably count to 10.
He can count, sure, but he doesn't understand value or quantity in an abstract way. To a 4-year-old, numbers are just labels like ABC. He doesn't inherently understand that 8 is twice as much as 4, or that 10 is a definitive limit. A 5-year-old, on the other hand, typically has developed that cognitive numeracy.
What would a 4-year-old do if you asked them?
They'll just guess a number they like. I'm a 7 because I'm 7 years old.
Right.
Or they'll just say 10 every time. It's completely unreliable.
That is a classic exam trap. Don't give the number line to the preschooler.
Don't do it.
Okay, so what if the kid is too young for faces? Or they're nonverbal? Or maybe they have a severe cognitive delay like cerebral palsy, and they can't communicate at a 3-year-old level.
When you abandon self-report entirely, you can't use it. You have to switch to an observational tool. And the gold standard here is the FLACC scale, or the revised version, our FLACC.
FLACC. Break that down for us.
It's another mnemonic. It stands for face, legs, activity, cry, consolability. You observe the child for about 1 to 5 minutes, and you score each of those 5 categories from a 0 to a 2.
So you're looking at their physical presentation, their body language.
Exactly. Face. Are they grimacing or clenching their jaw? That's a 2. A slight frown is a 1. Legs. Are they relaxed, or are they kicking and drawn up tightly to their chest? Activity. Are they lying quietly, or are they arching their back or jerking around? Cry. Is it just a little whimper or a full-blown scream? And consolability. This is a big one. Can you distract them? If you pick them up or rock them, do they stop crying? Or are they just completely inconsolable? You tally all that up to get a score out of 10.
And this is the go-to for infants and toddlers.
Infants, toddlers, and this is important, nonverbal children of any age. If you have a 12-year-old with a severe developmental delay who cannot speak, you use the FLACC. You don't try to force the faces scale on a child who doesn't understand the concept of matching their feeling to a drawing.
There's one more mentioned in the 80-20 list, the Oucher scale, which sounds kind of aggressive, but I guess it's accurate.
The Oucher is similar to faces, but instead of cartoon drawings, it uses actual photographs of children expressing different levels of pain. It's also for 3 years and older. The need-to-know nuance here is cultural. The Oucher comes in different versions. There's a Caucasian version, an African-American version, a Hispanic version, so the child can identify with the face they're seeing. It helps with reliability.
That makes perfect sense. Representation matters even in pain assessment. What about the nice-to-know stuff here? The source mentions some specific NICU scales.
Yeah, unless you're planning to go into the NICU, you probably don't need to memorize the scoring grids for these, but you should recognize the acronyms. NPS, that's the Neonatal Infant Pain Scale, CRY-SS, which is specifically for post-op neonates, and PIPP, the Premature Infant Pain Profile. If you see these on an exam, just associate them with newborn. That's usually enough.
And for the older kids, any other tools?
There is the APPT, the Adolescent Pediatric Pain Tool. This is for ages about 8 to 15. It's much more sophisticated. It has a body outline where they can actually color in where the pain is. It asks about the quality of the pain. Is it burning? Is it stabbing? Is it throbbing? It treats the child more like a mini adult, capable of a more detailed assessment.
Okay, that's a great overview of the tools. So moving on to section 4, developmental clues. We've picked our tool, but now we have to actually do the assessment. We need to play detective. Let's walk through the age groups because the presentation of pain just changes so drastically as the brain develops. Let's start with the infants.
The babies. With them, you are entirely dependent on spotting the physiologic changes. Think fight or flight.
So the sympathetic nervous system just kicks right in.
It goes into overdrive, heart rate goes up, respiratory rate goes up. But here is a critical exam detail that people often miss. Oxygen saturation goes down.
Why does the O2 sat drop if they're breathing faster?
It's a great question. There are a few reasons. They might be holding their breath while they're crying, which is called Valsalva. Or their breathing becomes really shallow and rapid tachypnea, which isn't efficient for gas exchange at all. So if you see a baby desaturating on the monitor, pain should be high on your list of possible causes. What else are we looking for? Palmar or plantar, sweating. Just touch their little hands and the soles of their feet. If they're clammy, that's a stress response. Changes in vagal tone. And behaviorally, the biggest thing is to look for guarding.
Guarding. What does that look like in an infant?
It's a refusal to move a body part. If an infant has a sore arm from an IV, they will hold it perfectly still, flexed against their body. If you try to extend it, they will scream. That rigidity is their way of splinting the injury themselves.
And the cry?
Oh, the cry. Listen to the cry. A pain cry is distinct. It's high-pitched, it's shrill, it's harsh. It sounds completely different than a hungry cry or a wet diaper cry. Experienced NICU and PEDS nurses can hear the difference from down the hall.
Okay, let's grow up a little bit. The toddlers and preschoolers, the Lucas age group. We already talked about how they might lie to you, but what else is going on in their little heads?
This is where magical thinking comes into play. Cognitively, toddlers often view pain as punishment.
Punishment for what?
For being bad. I hit my brother earlier, so now my tummy hurts. Or I didn't clean my room, so now the nurse is sticking me with a needle. They really struggle to separate the physical cause from their own behavior.
That is absolutely heartbreaking. It adds this whole layer of guilt and fear on top of the physical pain.
It does, and that's why they might kick, bite, or try to run away. In their mind, they're fighting off the punishment. They also have very poor body boundaries. If you put a Band-Aid on them, they might honestly believe that Band-Aid's the only thing keeping all their insides from falling out.
So when you're assessing them, you need to be very reassuring.
So reassuring. You didn't do anything wrong. This medicine is just to help your tummy feel better. That reassurance is absolutely key.
Now, the adolescents, the teenagers. They are cognitively capable of understanding pain, but they come with so much social baggage.
Huge social baggage. Their primary developmental drive is identity and independence, and their biggest fears are body image and loss of control.
So how does that manifest when they're hurting?
It often looks like stoicism. We mentioned the football player earlier. A teen might sit there stone-faced, scrolling on their phone while their pain is an 8 out of 10. They are terrified of losing control, of crying in front of you or their parents or, God forbid, their friends who might visit. They don't want to look like a baby.
So with a teenager, a calm exterior could just be a mask?
It's often a mask, yes.
Yeah.
You have to give them permission to be vulnerable, and you have to give them choices. Do you want the pill now or in 15 minutes? Do you want your mom to stay in the room, or do you want her to step out for this part? Giving them back just a tiny bit of control can lower their anxiety, which we know actually lowers their perception of pain.
That connects nicely to the nice to know notes here. School-age kids, that middle group, they're usually the easiest to assess, right?
Generally, yes. The 6 to 12-year-olds.
Yeah.
They have the language to describe the pain. It feels like a knife versus it just aches. And they understand cause and effect. I fell off my bike, so my knee hurts. They're usually your most reliable historians in the pediatric world.
All right, we've assessed the pain, we've found it, now we have to treat it. Section 5, pharmacologic management. This is the heavy lifter. This is where safety is absolutely paramount.
This is the section where the 80-20 rule really saves lives. We need to talk about the drugs, the side effects, and what I call the assessment loop.
Let's start with the big 3 categories mentioned in the text. How should we organize these in our minds?
It's a simple framework. Number 1, analgesics. This is your main pain-fighting category. It includes non-opioids like acetaminophen, Tylenol, and NSAIDs like ibuprofen. And then it includes the opioids morphine, fentanyl, hydromorphone. Number 2, adjuvants. These are drugs that aren't primarily painkillers, but they help with specific types of pain or with the anxiety that comes with pain. Think benzodiazepines, like Valium, for muscle spasms, or anticonvulsants, like gabapentin, for neuropathic or nerve pain.
And number 3,
Anesthetics. These are the numbing agents, lidocaine that you inject, or EMLA cream that you put on top of the skin.
let's focus on the analgesics first. The text mentions something called a ceiling effect. This feels like a classic nuance that exam writers would test on.
It is. It's a key distinction. Non-opioids, like ibuprofen, have a ceiling effect. That means there is a maximum dose where you get maximum pain relief. If you give more than that dose, you don't get any more pain relief, you just get more side effects like liver or kidney toxicity.
The curve basically flattens out at the top.
Exactly. But opioids, specifically the pure agonists like morphine, do not have a ceiling effect. Theoretically, the more you give, the more pain relief you get.
So why don't we just give massive doses and wipe out all the pain?
Because the side effects also have no ceiling. The limiting factor with opioids isn't efficacy. It is respiratory depression. You stop increasing the dose because the patient stops breathing.
And that brings us to the #1 need-to-know adverse event, respiratory depression. This is the ABCs of nursing: airway, breathing, circulation.
It is, but in practice, we need to be very specific about what that looks like. It's not just he's not breathing. It's a progression. It's a slide.
What's the first sign?
First, the patient gets sedated. They get drowsy. Then the respiratory rate starts to slow down. Then the depth of their breathing becomes shallow. And only then does the oxygen saturation drop.
So if you wait for the O2 sat alarm to start beeping, you are late to the party.
You are very late. The O2 sat is a lagging indicator. The need-to-know assessment parameters are sedation level and respiratory rate. If Lucas is on a morphine drip and he is unarousable, you can't wake him up by shaking his shoulder, that is an emergency. Even if his O2 sat is still 95%, he is on the verge of respiratory failure.
And the intervention in that moment?
Stop the infusion immediately. Stimulate the patients, shake them, call their name, and have naloxone or Narcan ready. But remember, Narcan reverses the pain control too. Lucas will wake up screaming in agony.
Yeah.
So you use it very carefully, titrating it if possible, to just bring his respiratory rate up without completely eliminating his pain relief.
Let's talk about the other side effects. The ones that won't kill them but will make them miserable. Constipation.
This is basically guaranteed. Opioids slow down bowel motility to a crawl. If a child is on opioids for more than 48 hours, they must be on a bowel regimen. Stool softeners, laxatives. You do not wait for them to get impacted. Prevention is key.
And pruritus. Itching.
Ah, yes. This is the classic fake allergy trap on exams. You give a dose of IV morphine. 5 minutes later, the parent hits the call bell and says, he's scratching his nose, he's allergic. The new nurse panics and thinks, oh my God, anaphylaxis.
Is he allergic?
Probably not. Opioids can cause histamine release, which causes itching, especially around the face and nose. It is a very common side effect, not necessarily a true allergy.
So how do you tell the difference between a side effect and a life-threatening allergy?
You look for the other signs of anaphylaxis. Are there hives, urticaria all over the body? Their child wheezing? Do you hear stridor? Is their blood pressure dropping? If it's just an itchy nose, it's a side effect. You can treat it with an antihistamine like Benadryl, or you can talk to the provider about switching to a different opioid. But don't immediately label that kid allergic to morphine without a full assessment. You might block them from getting necessary pain control for the rest of their life.
That is a crucial distinction. Now, the assessment loop. The source text is very, very firm on this.
The assessment loop is your legal and ethical requirement. It is not enough to give the pill or push the IV med. You must reassess. The standard of care is typically 15 to 30 minutes after an IV medication and 45 to 60 minutes after an oral medication. You have to go back to the bedside.
And what are you checking for specifically in that reassessment?
3 things. Number 1, did it work? What's the new pain score? Number 2, are they safe? What are their vitals? What is their respiratory status and sedation level? And number 3, are there any side effects? Are they itching? Are they nauseous? If you document the administration but you don't document the reassessment, legally, you abandon that patient.
Abandon the patient. That's a phrase that just chills the blood.
It should.
Okay, let's wrap up pharma with a need to know regarding dosing. PEDS is different from adults because...
Weight-based dosing. Everything is per kilogram. Milligrams per kilogram per dose.
Which means math.
Which means errors. The single most common cause of medication error in pediatrics is a calculation error. Moving the decimal point 1 spot to the right is a 10-fold overdose. If Lucas is supposed to get 2 milligrams of morphine and you accidentally give him 20 milligrams, that is likely fatal.
So the rule is?
Double check, triple check. Many hospitals require a 2-nurse check for high-alert medications like opioids and insulin. But even if they don't, you do your own math twice. Verify the weight, never ever guess.
All right, section 6. We are in the home stretch. Non-pharmacologic and procedural management. This is what I call the art of PEDS nursing. It's not just pushing meds, it's managing the environment and using your creativity.
And honestly, for a lot of minor procedures, needle sticks, IV starts, these are your primary interventions, or at least should be used in combination with meds.
Let's talk about sucrose, the sweeties. This sounds like an old wives' tale.
It sounds like it, but it's pure evidence-based magic for infants. It's a 24% sucrose solution, basically concentrated sugar water. You dip a pacifier in it, or you can put a few drops directly on the tongue.
And how on earth does sugar stop pain?
It stimulates the release of endogenous opioids endorphins in the infant's brain. It effectively drugs them with their own natural painkiller.
That's wild.
It works best for infants up to 12 months, although it's most effective under 6 months. You use it about 2 minutes prior to a procedure like a heel stick or an ID start. Combined with non-nutritive sucking, the pacifier, it significantly reduces pain scores.
So sugar plus a pacifier equals a much happier baby.
It's a proven formula.
Next up, therapeutic hugging. I love this term because the word restraint just sounds so barbaric.
And it felt barbaric. We used to do that.
Yeah.
Papoose boards, holding kids down, spread eagle on a table. It was incredibly traumatizing for everyone involved. Therapeutic hugging is a secure holding position. Usually the parent sits on the bed or chair and holds the child on their lap, securing the child's arms and legs with their own body in what feels like a big, tight hug.
So the child feels held, not trapped or attacked.
Correct. It provides comfort and immobility so the nurse can get the IV or the shot in safely. And it turns the parent into a protector and a helper rather than just a terrified spectator.
What about topical anesthetics? Things like EMLA cream or LMX.
These are creams that numb the skin. The absolute need to know here is timing. EMLA cream takes a full 60 minutes to work effectively. LMX is a bit faster. It takes about 30 minutes.
So you have to plan ahead. You can't just decide to use it in the moment.
You have to anticipate. If you know Lucas needs a blood draw at 10 a.m., you put the cream on at 9 a.m. If you walk in at 10 a.m. and say, oops, I forgot, it's too late, you're going to have to stick him without it. Anticipatory guidance is a huge part of good pediatric pain management.
And for the tiniest patients, the preemies there, is kangaroo care.
Skin-to-skin contact. You just place the diaper-clad infant directly on the parent's bare chest. The research on this is so robust. It stabilizes their heart rate, it improves their O2 saturation, and it significantly reduces pain scores during and after procedures. It's free, it's safe, and it promotes bonding. There's no reason not to do it.
Let's talk about the procedure itself. Sometimes we have a choice in how we hurt them, right?
We do. Procedural choice. This is especially true for newborns. If you need a significant amount of blood, the evidence clearly shows that a venipuncture drawing from a vein with a small butterfly needle is actually less painful than a heel stick.
Really? The heel stick seems so routine, so much less invasive.
But it involves squeezing the foot over and over to milk the blood out. That causes bruising and prolonged pain. A skilled phlebotomist doing a venipuncture is one quick poke, you get the blood flow, and you're done. So we should always advocate for the method that hurts less.
And finally, cognitive strategies. Distraction.
Bubbles. I always carry bubbles in my pocket. Do you know why they are the perfect tool?
Because everyone loves bubbles.
That's part of it, but there's a physiological reason. To blow a bubble, you have to take a deep breath in and then exhale slowly and controlled. It forces the child to do deep breathing exercises without even knowing they're doing it.
Oh, that's brilliant.
It lowers their heart rate, relaxes their muscles. Plus, watching the bubble float away is a powerful visual distraction. It helps gate the pain signal. The brain is so busy processing the bubble, it has less capacity to process the pain.
It's a breathing exercise disguised as a toy. I love it.
Guided imagery is another great one for older kids. Lucas, tell me about your favorite place. Is it the beach? What does the sand feel like? Can you hear the seagulls? Is the water cold? If you can get his brain to process all the sensory details of the beach, it has less bandwidth to process the pain signal coming from his abdomen. The brain can only focus on so much at once.
We have covered a massive amount of ground here. Let's bring this in for a landing with the summary. If the listener is driving to their exam right now or walking onto the unit for their shift, what are the gold standard takeaways?
Let's hit the top 4. The absolute must-knows.
Go for it.
Number 1, trust the assessment, but know the traps. Sleep does not equal comfort. Newborns feel pain. Kids will lie to you to avoid a shot. Believe the body.
Okay, number 2.
2, use the right tool. Faith is for 3 and up, but only if they understand the instructions. Numeric scales for 5 and up, and FLACC is for everyone who can't speak for themselves.
Number 3.
3, respect the opioids. They are safe and effective if you monitor respiratory rate and sedation level. Watch for that slide into sleepiness before the breath stops.
And the last one.
And number 4, advocate. Be the advocate. Use the parents as a resource. Use the sugar water. Use the numbing cream. Use the bubbles. Don't just document the pain. Do everything in your power to treat it.
And remind us of the why. Why do we care so much about this? It's not just about being nice.
It's not. because pain changes the wiring of the brain. Uncontrolled pain releases cortisol. It suppresses the immune system. It delays wound healing. A child in pain physically heals slower. And as we learned with the newborns, it can create long-term sensitization to pain. By managing pain well today, you are actually protecting that child's future interaction with the entire healthcare system. You are preventing medical trauma.
I want to leave everyone with a thought that really stuck with me from our discussion on the sleeping trap. It really challenges how we view our patients.
It does. It's the question I want every nurse to ask themselves when they walk into a room and see a quiet, sleeping child in a hospital bed. Are they peaceful, or are they just exhausted?
Explain that distinction one last time for us.
Peaceful implies comfort, relief, resolution. Exhausted implies a battle has been fought. If that child has been fighting pain for hours and finally collapses into sleep, that is not a success for us. That is a physiologic shutdown. If you assume peace when the reality is exhaustion, you will miss the pain and you will fail that patient. So look closer. Check the furrow in their brow. Check their palms. Check the history. Be the detective.
Powerful stuff. Thank you so much for this deep dive. To all the nurses and students out there, good luck with your exams, but more importantly, good luck with your patients. Be the advocate they need you to be.
See you next time.